So this voiceover is information on the first half of our endocrine lecture that I was unable to get through on this past Thursday. So briefly, I wanted to review how we assess the endocrine system, and in particular, the endocrine system in children. Weight, length, height, BMIs, all of those are important measures that we need to be checking over time and plotting on those growth curves, because changes in growth and development does give us some indication of potential endocrine complications. Vital signs with a special attention paid to blood pressure. Facial characteristics, they can have a moon face, they can have eyes that are maybe more bulging, they can have tongues that are protruding, various different characteristics like that, which I will be talking about when we talk about one or two of the disease processes. Thyroids need to be felt for the presence of a goiter. Muscles, how good is our muscle strength and tone? Some of our endocrine disorders come with poor muscle tone. Stage of development with regards to secondary sex characteristics and staging those children. When we look at some disease processes like precocious puberty, it is important for us to be looking at those secondary sex characteristics. Body odors can be, believe it or not, associated with certain conditions, so we need to be aware of those. And finally, looking at skin for color and pigmentation changes. So the first disorder I want to look at is growth hormone deficiencies, also known as hypopituitarism. This is a decreased activity of the pituitary gland, and as the title indicates, it is secreting not enough growth hormone. And so what it does is it inhibits the growth of the child as well as the development of secondary sex characteristics. So growth hormone is responsible for the linear growth in all of us, as well as that mineralization of our bone. And in many cases, when we look at the age chronologically versus the age in growth of the body, we look at bone growth and bone mineralization densities in order for us to determine that. And if there are differences between chronological growth and bone density growth, then we kind of look at whether we have growth hormone deficiencies or growth hormone excess. There are numerous causes of growth hormone deficiency, but all of them interfere in some way or another with the production and or the release of growth hormone. So what does growth hormone deficiency look like in children? Well, these children will be born with a normal birth weight and length. However, at approximately 1 year of age, they'll begin to fall off, rather dramatically fall off that growth curve in those charts. And we'll see them fall in many cases below the third to the fifth percentile. They may also have such things as hypoglycemia and seizures associated with that. They may have things, undescended testicles. They may have what is described as a cherubic appearance. So they have very youthful facial features, higher pitched voices, delayed skeletal and sexual maturation. So they look sort of like that Valentine cherub that we may see that are very young and youthful in appearance. Any child's height who is 2 to 3 standard deviations below what we would consider the mean height for that age bracket needs to be evaluated for growth hormone deficiencies. So in terms of treatment, the first thing we will do is determine, as I mentioned a few minutes ago, bone age versus chronological age to determine does this child indeed have growth hormone deficiency and differences in growth. If we determine that indeed they do, we will be administering growth hormone. This is a tough regime, as these children need to get about 6 to 7, depending on the child and the regime, subcutaneous injections of growth hormone every day. And that can be a challenge. And again, thinking of the development of the children and where they're at, involving them in that as they are capable is very important. They will experience a rapid growth rate in that first year, and then it sort of begins to settle out. And growth should continue at least on until the normal rate of age while children are on growth hormones. So we want them to be growing at a normal rate after that first year rather than that increased velocity of rate that we see in the first year of treatment. So growth hormone excess is the opposite, and that's hyperpituitarism. And this is when the pituitary is secreting too much growth hormone. We don't see it very commonly in children, but when we do, we will see these kids reach between 7 and 8 feet of height, believe it or not. Treatment depends on the reasons for that excessive growth hormone release. And finally, we'll look at precocious puberty. Precocious puberty is defined as the appearance of secondary sex characteristics before approximately 8 years of age in young girls. And those secondary sex characteristics we look for are breast development and pubic hair development. And before 9 years of age in boys. And in those children, we look for pubic hair or genital development. It is not usually associated with an endocrine system abnormality. There's usually external sources of hormones, maybe steroids or estrogen, that can be identified as a cause as well. So central precocious puberty, we have two different types, central and peripheral. Central precocious puberty is considered true precocious puberty and occurs when the hypothalamus is activated to secrete gonadotropic releasing hormones. So for whatever reason, the hypothalamus is stimulated. About 80% of precocious puberty cases are central precocious puberty, and it results in the early maturation and development of the gonads and secondary sex characteristics. Peripheral precocious puberty is just the premature development of breasts and pubic hair, axillary hair, menstrual cycles, and that is generally not required to have treatment if it is just that development. So obviously what we may see in precocious puberty is that we may see advanced bone growth. So again, we're looking at bone mineral densities. But they may appear unusually tall for their age initially, but growth will eventually slow and hormones will stimulate the closing of the epiphyseal plates, resulting in a short stature. So we don't want that to happen. We don't want those epiphyseal plates to close too early, which would be the risk if we are in precocious puberty without treatment. The treatment is giving an agonist to the gonadotropic releasing hormone. Something like Lupron is given. And they get monthly injections with this, which will decrease the release or be an agonist to the release of gonadotropic releasing hormone. And in doing that, it will slow down the process of reaching puberty and will inhibit the closure of those epiphyseal plates. And once the child reaches the normal age for puberty, the treatment will stop.